Hi, thank you so much for the privilege to present. I have no relevant disclosures. You can enjoy beautiful Strasbourg, France during the 7-second interlude where we performed the AI study models. So artificial intelligence has great potential to impact the personalized treatment strategies in rectal cancer, where the treatment paradigm is changing and the local recurrence with that remains unknown. So with this, we first performed a retrospective review of an institutional rectal cancer registry to find low rectal cancer patients who had neoadjuvant chemoradiotherapy, a specific TATA surgery, and 2-year follow-up at least. From this, we developed actual local recurrence rates. Then, we applied multivariate model analysis using 6 different models to assess the predictive performance of AI models for local recurrence in rectal cancer patients after supposedly curative therapy and surgery. After using traditional models, we applied the proprietary Stagel algorithm that performs deep feature selection and identifies what's essentially an immune fingerprint for a disease state. Our second outcome here was the predictive performance of the Stagel algorithm for identifying biomarkers related to local recurrence in rectal cancer patients. After reviewing the registry, there were 211 patients that met inclusion criteria, 10 with local recurrence, so small sample size to start with. With the algorithm, we were able to find that there were significant differences in the predictive distribution between patients that had rectal cancer and didn't have rectal cancer. When we started applying the multivariate models to this, you can see that none of them were actually great, none of them that would be safe enough to actually impact our treatment paradigm. They had near good predictive ability, and the best was the Ridge, which was 0.691, and with 1 being perfect and 5 being basically unusable. After this, we went on to using the Stagel algorithm. Well, this is able to filter out the noise from all of the other variables, and there's 154 variables in our registry, to identify 10 novel variables that had the highest likelihood of predicting local recurrence. An open surgery approach, having scar configuration after a post-radiation assessment, and elevated CEA levels before neoadjuvant chemoradiotherapy, all had more than 90% predictive ability. And then 7 others that are basically novel variables that we don't talk about that were also very highly correlated. We then validated this using 3 validated models for multivariate analysis and saw that there was very good predictive performance for the Stagel algorithm, better than for the AI algorithm assessment alone. So, fast summary, papers in review already, which I encourage you to read because there's a lot of details that go into this. But the results are actually really exciting. There's moderate performance just for predicting local recurrence using traditional learning models that we have, but the Stagel algorithm can outperform the other methods, have very good predictive ability, and this is in a very small sample size. It identified 10 biomarkers associated with local recurrence that could essentially help develop a fingerprint for the disease and help further transition to patient-personalized precision care. So stay tuned for more details here.
Thank you. Are there any questions? Dr. Keller, the variables that I noticed in your report were associated with a higher likelihood of recurrence, and those are some of the same common variables that we already examine. In your opinion, do you think AI is nothing more than a sophisticated model that still relies on the unsophisticated human to program it?
I think that it does definitely rely on the unsophisticated human because you have to provide direction or else you're going to come out with unexplainable AI, things that things that might be dangerous, things that you can't predict, things that you can't modify. So at the current time, we still do need interventions to help guide the machines, but they are definitely able to process data and identify patterns in a way that we are not able to. And I do think that some of the variables that they've identified are not things that we normally look for. And I think that this could also help us as we're developing new templates for NAPRC and ongoing quality work.
What are some of the variables that you would include to improve this model?
Well, For starting, doing a post-radiation assessment, I think, is critical. And we know that not all of our colleagues do this, and then guiding the management based on that. Because looking at tumor size was a huge factor, both at the post-radiation assessment and initially, and also the configuration of the tumor and the configuration of the tumor response, especially if it's a scar. You know, we think a scar is a complete response, and this is the highest likelihood of recurrence.
Exactly. Thank you.
Sure. Thank you very much.